I'd like to start by thanking Dr. Venkat and the iFix team for inviting me here. It's always a pleasure to speak at Ganga. I'm going to give a brief outline of the treatment of fracture of femur. So when we see a femur fracture, we divide them into age groups for treatment: neonates and infants till 6 months, 6 months to 5 years, 5 years to 11 years, and then you have the adolescent 11 years to skeletal maturity. Our treatment also depends on the level of the fracture, the pattern of the fracture, whether there's comminution or not, whether there are associated injuries, and whether it's a traumatic or a pathological fracture. Neonatal fractures, 0.13 per 1,000 live births. It's usually a spiral fracture of the proximal femur, with the proximal fragment will be flexed. The good news, as everybody's already spoken, there's thick periosteum, there's excellent remodeling potential. But the only difficulty there, it's a very small child. What do? You can splint the child, you can put the child in a spica very rarely, but most commonly we all use a Pavlik's harness to treat this injury. Okay, and this is described by Dr. Wilkins first. Example, a spiral fracture in a newborn in a Pavlik's harness, and you can see even at 10 days, a lot of callus. 1 month later, you can see the remodeling which occurs, and 6 months later, it's an almost straight femur. So that's how simple newborn fractures are. 6 months to 5 years, you can either do an early spica, straightaway spica close reduction, or you can do a traction and spica. What are the pros? It's a high success rate, it's very low technology, you don't need to operate, you don't need to take the child to anesthesia. The cons: nursing care, hospital or home, requires a family capable of managing the cast, which is a problem in our country, and it may require a family member to be off for 6 to 8 weeks. 4-year-old child treated with a Thomas splint, traction, and then put in a cast. 3 weeks. 2 months, you can see this angular angulation, and as everybody spoke about, you can see that it starts remodeling fast enough. So that's how well these children can be treated very easily with no surgery. 4 to 5, though, is a gray area. And you can do either early spica casting, you can do traction and spica casting in this age group, you can do submuscular plating for some difficult fractures, and you have the flexible intramedullary nails. I'll come to that later. 5 to 11 years is sort of solved now. You can treat them with TENS, the titanium elastic nailing system. You have submuscular plating, which can be done. And you also have external fixation. So these are modalities to treat the children in this age group. But what has gained predominance in the last few years is the TENS. This seems to be the acceptable form of treatment now, and it's currently the gold standard in this age group for treating fracture shaft of femur. What are the advantages? You shorten the hospital stay, early mobilization, avoid complications like shortening greater than 2 centimeters, angulation greater than 15 degrees, avoid hassles of POP care. But there are limiting factors. You generally can't do this in children above the age of 11 years and those who weigh more than 49 kgs. This is an example. I said 4 to 5 is a gray area. This is a proximal shaft femur. Child is a little fat. I decided to do a nailing. That just shows that the convexity of the nail is at the fracture site. Then goes on to heal well with no real problem. 3 months post-op, you can see it's remodeled well. 8-year-old male, this is the classic indication for a 10-nail mid-shaft fracture. You can see a plaster there. You can either put a knee brace. I just tend to put a above knee slab. That's to just control the knee for about 2 weeks. Goes on to heal well with no residual problems. There are what are called length unstable fractures. I spoke about fractures with comminution. Like this one, there's a huge butterfly fragment. There are ways to deal with this, even with nailing. So you can use a simple external fixator. This is just K-wires with a JES to maintain the length of the fracture. And then that's just to check that the rotations are normal. And then this goes on to heal very well. So that's how you deal with length unstable fractures. Adolescent fractures. This is a 13-year-old boy with a closed fracture of the femur of the patella, treated elsewhere with an orthofix, external fixator and screw fixation of the patella. Presented 8 months later with this picture. And this is what was done. I did a nailing, but I was careful to use a trochanteric entry nail. You do not enter through the piriformis fossa in this age group. That goes on to heal well. That's 1 year later, and 2 years later, so no sign of an avian. So in conclusion, there are different methods of treatment that are dictated by the patient's age, fracture characteristics, social situation of the family, important in our country. And in the past 15 years, we have seen a trend away from the non-surgical treatment towards surgical stabilization of these fractures. A number of different options are available: elastic nails, rigid nails, and the minimally invasive plating. Thank you very much.